Hello, my name's Sarah Brand. I work for Nottingham University Hospitals Trust, and today I'm going to be talking about knowledge sharing, specifically to support long-term condition self-management.
My name is Sarah Brand. I work at Nottingham University Hospitals Trust, and today I'm going to be talking about knowledge sharing, specifically to support long-term condition self-management.
In the UK, effective management of long-term conditions is seen to be one of the greatest challenges facing healthcare services. Individuals' health-related behaviours strongly influence the prevalence and course of disease and illness, and the associated requirement for healthcare interventions. One of the proposed solutions for the challenge posed by the increasing prevalence of long-term conditions is to support patients to better manage their conditions themselves, thereby reducing the uptake of healthcare services and the progression and severity of disease. There have been a range of programmes internationally designed to promote self-management. A common theme within these programmes is to build individuals' knowledge, skills and confidence, both in their condition and the management activities associated with it. Most self-management programs involve some type of patient education, and this largely refers to healthcare professional-led programs of education and skill development. The assumption is that knowledge can be given to patients, the main issue being ensuring that they use this knowledge to inform their behaviours. More recently, the personalised care and shared decision-making agendas have required increased knowledge sharing, not just from healthcare professionals to patients, but from patients back to healthcare professionals. Recent healthcare policy recognises that patients have unique knowledge of living with illness and receiving healthcare services. It is assumed that this knowledge based on experience can be complementary to healthcare professionals' clinical knowledge. There are a range of social factors, however, which can make knowledge sharing between patients and healthcare professionals complicated. Actors sharing knowledge come from different worlds, occupy different social roles associated with differential status, and communicate in unique ways. This social context and the cultural norms associated with it can be so embedded as to be imperceptible to the social actors operating within it, but nevertheless imperative to recognise in order to understand the setting in which healthcare is enacted. In ignoring these social and cultural factors, the impact of self-management interventions may be limited, and frustrations on the part of healthcare professionals who are committed to promoting self-management may be heightened. It's worth here considering briefly what we mean when we talk about knowledge. In this study, knowledge was seen to be more than data or information. Knowledge is formed when data or information is transformed by the individual as they apply their own personal values and beliefs. It's not therefore an entity in itself which can be given, received or lost, but something intrinsically associated with the actors involved and transformed in its sharing. This study utilised an ethnographic approach, using observations and semi-structured interviews. The participants were patients who were living with a long-term condition and the healthcare professionals who were caring for them. The data was analysed thematically using the constant comparative method. When the data was analysed, 4 main themes emerged. It was evident that both healthcare professionals and patients had clear understandings of their identity within interactions and what behaviour was expecting when occupying these roles within healthcare. This influenced how they approached knowledge sharing specifically. Healthcare professionals saw knowledge sharing as a key element of their role, particularly in relation to ensuring that patients had the essential knowledge required to understand and manage their conditions. It was assumed that it was the healthcare professional's role to provide knowledge to patients who would know very little about their health conditions. The patient role was also associated with a responsibility for knowledge sharing with healthcare professionals, but this was primarily to allow healthcare professionals to do their prescribed function of making diagnosis and treatment decisions. It was apparent that part of the patient role was not only to share knowledge, but also to follow the advice of the healthcare professional. This was not articulated, but was apparent in observed behaviours. It would appear that openly disregarding healthcare professionals' knowledge and the ensuing advice was difficult for many patients, and they understood that this violated some social norms. In contrast, healthcare professionals did not find any difficulty in disagreeing with knowledge offered by patients. It was clear that whilst both healthcare professionals and patients felt that it was their role to share knowledge with the other party, it was only incumbent on patients to utilise the knowledge that was shared with them. This articulated responsibility to share knowledge belied the complexity of knowledge sharing in practice, however. It appeared that knowledge sharing differed dependent on the professional role of the healthcare professional involved in the interaction. This was not only related to the knowledge shared by the healthcare professional, which might be assumed given the different core knowledge bases of different professions. It also related to the knowledge which patients shared with the healthcare professional, sharing different knowledge with different professional groups in a nuanced way unrelated to the questions which the healthcare professional asked. This appeared to be related to the professional role of the healthcare professional, their perceived empathy with the patient perspective, and their likely response to sharing of some particular knowledge. Healthcare professionals appeared to be aware of this in their routine interactions and accepted it as an element of multidisciplinary team working. This differential knowledge sharing necessarily influenced the assessment and decisions made by healthcare professionals regarding clinical management and self-management behaviours. Nurses tended to be used as conduits through which difficult knowledge could be shared and communicated to other professional groups, primarily medical staff. The input of the multidisciplinary team in caring for patients with long-term conditions appears to offer opportunity for more comprehensive knowledge sharing to take place, particularly from patients to healthcare professionals. It's widely understood that different healthcare professionals will share distinct knowledge as part of their professional roles, but it also appeared that patients may also share different knowledge with different healthcare professionals. Whilst this may be related to the individual characteristics of the healthcare professional, it also appears to be intrinsically associated with their normative professional role. The link between knowledge and expertise has been a long one. Being an expert and having expertise in this context was almost exclusively associated with healthcare professionals. They were the accepted experts in healthcare by both patients and healthcare professionals themselves. In the view of patients, occupying a professional position was tantamount to possessing expertise. More specifically, holding a professional position provided surety of qualifications, clinical knowledge and skill. Given this understanding of experts and expertise as exclusively associated with professional position, it is not surprising that patients did not identify with the label of expert. This lack of identification was largely centred around a lack of clinical knowledge specifically, which it was assumed was essential for all experts to possess. This was despite the fact that a number of patients carried out highly technical life-saving treatments for themselves in their own homes. Experience was commonly articulated as an alternative explanation to expertise for how patients viewed their own capabilities, but was not, in their minds, sufficient to warrant the label of expert. There were some circumstances, however, in which patients' experiential knowledge did lead to the assignment of expert status. In one study site, information sessions were held in which treatment information was given to newly diagnosed patients, and some experienced patients were invited to attend in order to share their knowledge of their lived experience of their illness and treatments with other patients. They were overtly called expert patients in this setting. The experiential knowledge and perspective gained from lived experience was seen to be very important by healthcare professionals in this context in particular. They understood that these patients could offer knowledge which they could not as healthcare professionals. Whilst patients appreciated the value of their experiential knowledge in this context, clinical knowledge remained paramount in the categorisation of being an expert in the conventional sense. Therefore, on a personal level, they did not see their own experiential knowledge as contributing to them being an expert. For them, experiential knowledge was of a lower order than clinical knowledge and therefore did not constitute expertise or the associated label of expert. It would appear that clinical and experiential knowledge were valued differently within the healthcare context. Routinely, clinical knowledge appeared to be much more highly valued than experiential knowledge. Within healthcare consultations, patients' experiential knowledge could be easily dismissed, being overridden by the clinical knowledge and decision-making power of the healthcare professional. It also appeared that the role of the patient was not commensurate with contributing clinical knowledge to healthcare interactions. This appeared to be the remit of the healthcare professional. Patients reported experiencing issues if they attempted to contribute clinical knowledge within routine consultations concerned with their own healthcare management. It would appear that clinical knowledge was deemed to be exclusively the remit of the healthcare professional, and if the patient attempted to present this type of knowledge, the interaction was disrupted and unproductive. Therefore, not only did clinical and experiential knowledge have differential value within clinical consultations, but also each type of knowledge was closely associated with normative social roles, clinical knowledge with healthcare professionals, and experiential knowledge with patients. Whilst this could be problematic, some patients recognised these dynamics within interactions, and it led them to adopt specific knowledge sharing strategies within consultations in order to maintain the ease of interaction. Knowledge sharing was underpinned by normative social roles, how knowledge was valued, what knowledge could be shared when and how, and itself perpetuated these roles within the practices seen in interactions. Despite being a knowledge-rich environment, knowledge sharing is complex within healthcare. There are barriers to comprehensive knowledge sharing, many of which have their foundations in cultural issues of accepted and embedded social norms. These roles influence what knowledge is shared between actors and how this is achieved. Whilst both patients and healthcare professionals view knowledge sharing as essential elements of their roles, their perceptions of the value of their differing knowledge pose challenges to how readily it was shared in practice. Patients found it difficult to recognise their expertise and the value of the experiential knowledge which they had developed, and this in turn made it challenging for them to confidently share it within routine interactions. A deficit model of knowledge is common in healthcare and underpins most self-management programs, which assumes that patients have insufficient knowledge in order to self-manage. The goal of healthcare is therefore to furnish patients with the knowledge which they require to manage their conditions on a daily basis. In contrast, this study would suggest that it is not necessarily a lack of knowledge which is the issue, but rather an undervaluing of the unique experiential knowledge which patients have and a corresponding lack of opportunity to effectively utilise it within the decision-making processes embedded within the routine healthcare interactions. Endorsement of patients' experiential knowledge in policy is not in itself sufficient to promote the cultural change required to support a more equal relationship between patients and healthcare professionals. Therefore, the personalised care and shared decision-making agendas remain problematic to operationalise in practice on a daily basis. Understanding these social and cultural contexts is the first step to developing strategies to overcome these challenges. Thank you for listening.